All right, I did want to offer some kind of honorable mentions about products before we go into algorithms. So there are some anticonvulsant type products that can be helpful in anxiety, like pregabalin or Lyrica, and gabapentin or Neurontin that can help. We also can see some glutamate type products that can have some potential benefit as well, like lamotrigine, for example. Occasionally, we will use antipsychotics, and some of those will be included in one of these algorithms. So this certainly wasn't a fully comprehensive series that talked about all of the medications in detail. Just sort of a general overview to allow for a basic understanding of what kinds of products and where their spaces are. Understanding that different products have different roles for different conditions, but we also have people who might have multiple conditions. So the challenge sometimes is balancing all of those things together. Now, from an algorithm perspective, in general, if someone presents with MDD, we can offer psychotherapy and or an antidepressant, usually an SSRI. That being said, that is not the only potential option, right? So what we can see is the potential for other choices too. So we have SSRI, SNRI, Arnasa, NDRI, trazodone, vilazodone, vortioxetine. All of these can potentially be good first choices. So it's almost easier to try to remember the exceptions than the rule for initial options. So things like tricyclic antidepressants, MAOIs, any of those added products that we had talked about later on wouldn't be appropriate to offer first. Okay, so you wouldn't give someone lithium as their only medication to treat major depressive disorder. If they had bipolar with depression, that could be appropriate, right? So the diagnosis can make a difference there. So 4 to 6 weeks of treatment, and really taking into consideration, are they taking it? Are we maximizing the dose? Are they tolerating it okay? Then we can consider either changing the product, augmenting, maybe even using a higher dose, adding psychotherapy. So once you get through that first step, there's a lot of flexibility in terms of how we could potentially alter their therapy. After that, then kind of keep rotating through, trying an alternate product, augmentation, as well as the potential for electroconvulsive therapy. So really thinking about it from the first line of treatment, the first options for treatment, because most people are going to be sitting there, right? Once someone does well on a product, then or psychotherapy, then usually treating for about 6 months is appropriate. If they're still doing well, it's their first episode, we can back off. And they may never need treatment again. If they've had 3 or more episodes, then we typically will have them in a maintenance phase that does not end, right? So data supports in general that people will have a pretty significant risk of relapse of their symptomatology without treatment. And that goes down if they stay on a treatment. We're thinking about therapy targets. We want to monitor them every couple weeks until they're stable, and then monthly afterwards, particularly if it's an anxiety situation. So if they have anxiety, using a 12-month treatment is going to be a bit more appropriate. So with our depression, 6 months at first. With anxiety, we want 12 months typically. Okay. A lot of times we might need to check in with them a little bit more often with anxiety versus depression as well. Now, to break down the individual conditions, so for GAD or PD, so generalized anxiety or panic, starting with an SSRI or SNRI, plus or minus a benzodiazepine. Okay. From there, then we can start thinking about Buspar, hydroxyzine, pregabalin, and considering maybe introducing benzodiazepine if they hadn't had it prior to that. And then this is where some of the antipsychotics, so the SGAs or second generation antipsychotics, can sometimes have some benefit for individuals. Again, those are not FDA approved, but occasionally we might use those products to help out depending on the types of symptoms that the person has. Really, at the end of the day, we look at someone's symptoms and we try to treat those symptoms. So if they have a lot of ruminative thoughts, and sometimes severe anxiety can look a little bit like psychosis, where their reality testing is a little bit unusual, and they might benefit from a second generation antipsychotic. In these cases, we should continue treatment for 12 months or more. From PTSD perspective, so from diagnosis, the recommendation is an SSRI. If you want to be more specific, fluoxetine, paroxetine, or sertraline. I'm not a huge fan of paroxetine, so in general, I usually try sertraline first. That's my personal preference, is for sertraline because of its tolerability, its drug interactions, etc. But any of those would be appropriate. For testing purposes, SSRI, right? From there, changing the SSRI if they don't tolerate it or they don't respond appropriately, and then venlafaxine. Some guidelines will have venlafaxine or Effexor earlier on in the treatment. I'm fine with that in most cases. The challenge with venlafaxine is it does have a more significant withdrawal phenomenon. So being thoughtful about that, some of the risk versus benefit, I'd like to try a sertraline type of product first. If they don't do well there, or say they have bipolar illness, right? So they could have PTSD and bipolar, then I'm going to go for an antipsychotic, right? So quetiapine is appropriate monotherapy, maybe risperidone. So quetiapine or Seroquel. If they don't have that risk and we want some other options, then we can think about using a combination of an antidepressant like venlafaxine or an SSRI plus quetiapine or potentially prazosin if sleep-related disturbances is a big consideration. We do not use benzodiazepines in PTSD, and I cannot stress that enough. If the primary thing that you're treating is PTSD, please do not use benzodiazepines. The reason for that is it essentially makes it difficult for them to get better, more or less. Benzodiazepines alter memory, and trauma treatment, trauma processing requires recollections of memories. And in order for someone to be able to bring a memory towards their working memory and to, approach it without, in order to process it, they need to remember. And what has been found is benzodiazepines will not improve PTSD and can also worsen the core symptoms of PTSD. Now, there might be cases that someone has a PTSD diagnosis and needs to take a benzodiazepine for panic, etc. And, trauma therapy, you got to be in a good space to do it. So that doesn't mean that everyone who has a diagnosis should not be using benzodiazepines necessarily. But it does mean that if someone is doing trauma therapy, benzodiazepines are going to make that pretty much not useful, more or less. Okay. Lower level options, there are other things that we can do like mirtazapine or tricyclics. But really what's important to know from my perspective, SSRI, venlafaxine, prazosin, quetiapine, no benzos. Okay, that's the high and low of that. From an OCD perspective, psychotherapy is gonna be it's better than antidepressants in most cases. In terms of dosing of antidepressants, we'll start with SSRIs for 6 to 8 weeks at a moderate dose. A lot of individuals may need higher doses, so we go up to maximally tolerated doses. So if you see someone that's on fluoxetine, 100, 120 milligrams, more often than not, it's going to be for OCD treatment. From there are other choices that we'll run into, like clomipramine, which is a tricyclic. But really, psychotherapy, SSRIs, those are going to be your top choices when it comes to options for treatment here. Benzodiazepines don't tend to help OCD, but unlike PTSD, they don't tend to have harm with OCD. So they may help with some of the symptomatic distress that is caused by OCD, but don't really do much to actually improve treatment. Okay. We will sometimes use antipsychotics, And if someone has those significant intrusive ruminative thoughts, that can potentially be quite beneficial for individuals. So again, SSRIs are our first option. As you go down, venlafaxine, clomipramine might be a choice. Benzos aren't super helpful, and people tend to need higher doses. So to wrap all of that up, depression is a really prevalent illness. It can be very disabling. We tend to use SSRIs first, but there's plenty of options that are available that can be appropriate to use first as well, based on things like adverse effects, how well someone's done on a medication in the past, what their comorbidities look like, what their adherence looks like. So if someone has, a really bad, like Crohn's disease or IBS, maybe a medication known to cause a lot of diarrhea is not a good choice. Some patients will need augmentation. They may need a lot of trial and error and just reminding them of that. Even if someone uses psychotherapy, it may take 2, 3, 4, it took me like 5 tries to find a psychotherapist that benefits me. It's just finding the right one for them, which can be really hard when you're not feeling well. From the anxiety perspective, start low in most cases and titrate slowly. Short-term benzodiazepines in acute crisis level anxiety where we need a rapid response, however, not helpful in PTSD. Avoiding that abrupt discontinuation for anyone who is taking medications long-term, particularly benzodiazepines and antidepressants. That's it. We did it. I got through it all. Hope you enjoyed it. Thank you for listening. Take care. Bye.